الأستاذ الدكتور حسام زيادة، أستاذ في جامعة الأزهر، هيقدم لنا secrets in curvature maps.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. I'm the last speaker, so the old time is now for me. يعني ما تاخدونيش بقى حاجة. I will go through two presentation. The first one will be the curvature map secrets, and the second one will be the new tools with increased sensitivity. No. ثانية. My dear colleague Dr. Hossam covered in very detailed way the curvature map and the statistical analysis and the numerical values regarding the pentacam. No, ثانية. So I will run very fast through this part, and I will focus on the secrets in the topographic maps and the posterior curvature map as well, because it's now more important than the curvature, the anterior curvature map. The posterior curvature map is a very sensitive map regarding the early detection of keratoconus, because the keratoconus is a posterior disease, not anterior disease. So the curvature map posteriorly will change very, very early than the anterior one. We have no financial interest, and the concept is the theme of this session. Regarding the refractive surgery, the refractive surgery is both examination and at the same time risk assessment before going to do something for this person. It's not patient, because actually he is seeing well with the glasses or the contact lens, but he's going to see better without. So examine carefully as a perfect meticulous ophthalmologist, and decide slowly as a wise judge, and plan finally as an engineer. So the basic knowledge we have shown, also the cutoff points. You have to know the cutoff points and rules, and give yourself a safety margin in all maps and all figures. Finally, please ask for the higher and the newer tools to get the higher sensitivity and the specificity to judge your patient. And finally, the minds are changing a lot nowadays. All these investigations you have, if you have to go through all of them. Nowadays, the pentacam itself is not more enough to judge your patient without asking for another, like the biomechanical studies and the epithelial mapping, as I will show in the second presentation. So we have three kinds of patients: either normal, abnormal, or innocent but not fit. And you know the difference between the topography and tomography. This is the surface and the depth. We have two styles of the curvature maps: tangential and axial maps. So which one of them you will rely on regarding the refractive surgery? Actually, the axial is more plain and much easier to calculate, but it's with wide gaps. So if you need to be more meticulous and to detect the early abnormalities, you have to ask for the tangential maps, not the axial maps, because the tangential maps will calculate the surface of the cornea or the back of the cornea in very close and very minute points. And for the sake of time, we will skip all of these slides. But nowadays we have a new era regarding the OCT-based tomography with the Placido disc, which is combined in the MS-39. And actually MS-39 user since 2022. So I believe that the Placido desk tomography is the most reliable and accurate sensitive one because it's a true topography. The Placido desk is a true topography rather than the Pentacam given topography, which is given by the calculation from the tomographic maps and information. But if you want to know about the surface perfectly and truly, you have to ask for the Placido desk, which is very more sensitive. But the drawback in the Placido desk is that it will be affected muchly by the dry spots, the opacities, and the tear film instability. Okay, so on the interpretation of the tomography point printout, you have to check 15 points in your investigation. And as you see here, you can run through them. But the most important thing here that you have to know that the patient has two eyes, not one eye. Even if you are going to correct one eye, you have to ask for capturing both eyes, because you may detect some pathology in the other eye which is not subjected for treatment. And finally, you have to correlate the topographic data with the clinical science, and don't forget that you are ophthalmologist. All these data were covered. And we have here two types of the composite maps. The first one is the 4 composite map, and the MS39 giving 6 composite map. And you will find here 2 maps more than the Pentacams print out. The posterior curvature map here down in the middle, and on your left side the epithelial thickness mapping, so increasing the validity and specificity of your judge at the end. So the anterior curvature map by Placido or Schimflag or slit scanning, the orb scan, and I talked about the axial versus tangential maps. And I said to you that the tangential maps are more accurate in detection of the defects, cone apex, and slope changes. And what about the color coding, and the style of the map, normalized or absolute scale? So the relative or normalized scale is individualized to the measured cornea, while absolute or standardized is based upon the same scale for the all corneas. So the standardized is for the screening, but the normalized or the relative for the individualized patient himself. So the absolute scale is recommended in the keratoconus diagnosis as well as in comparison. And don't forget that the tide colors coding scale is more accurate than the lax color, which is missing a lot of early pathologies. The green color is friendly while the red is enemy. But hence here that you have to review this point on reading your Pentacam. The width of the scan, either on the 0.25 diopter or 0.51 or 1.5. The standard one and the commonly used is a 1 diopter gap. But if you suspect anything in your printout, you have to ask for another one, to ask for 0.5 diopter to be sure that there is a pathology or not, to exclude or to confirm your pathology. But on screening, you are going for 1 diopter or 1.5 diopter gapping in the color coding or on your section. But if you suspect, please ask for another one. These are examples for the typical maps regarding the symmetrical bow tie, as you see here in the sagittal maps. While the atypical maps may be shown in these examples, showing the missed parts in the peripheral parts. As you here, you'll find this image, or the skewing in the different parts, or inferior steepening in the with high elevated points in the inferior part of the cornea. And so the cutoff points here, this is the important point to talk about. What about the surface asymmetry index in the superior and the inferior points in the central 3 millimeter, 5 millimeter, and 7 millimeters at the end? How to judge? You have to find them equal. But if they are not equal, how to judge? How to which difference you have to accept and you have to suspect? As we know in the rules, that the superior and the inferior points should be equal, or the difference between the superior and the inferior points not exceeding 1.5, while the inferior is higher or bigger than the superior. The superior stiffening is less suspecting or less important than the inferior. The most important is the inferior stiffening, so we will focus on it. But actually, I'm not forgiving the difference nowadays. There's nothing to say that if the difference 1.5 diopter, but I have another suspecting points in the other maps, I can suspect. No, the central 3 millimeter should be equal, and the difference shouldn't exceed 0.5 diopter in the central 3 millimeter, but in the central 5 millimeters, the difference between the inferior and superior points shouldn't exceed 1 diopters, until you have an explanation for this difference by opacity, by tear film pooling, or epithelial hyperplasia, as you will see in the epithelial mapping. But please keep in your mind that the inferior stiffening should be alarming sign, whatever the difference, even if less than 1 diopter, until you can explain it clinically or by other investigation. But in the central 3 millimeter, you have to find them equal with no difference. If the difference is 0.5 diopter or more, please think again and ask for more investigation for this patient. Rather than the skewing and the abnormal shapes, you have to explain by the misalignment, by the large angle kappa, by corneal opacities, or if there is nothing to explain, suspect this patient as a keratoconic until proved otherwise. And this is examples for the angle kappa covered by Dr. Hossam and Dr. Omar. And here is a summary of what have been shown. And let's go to the practice in such patient. This is a topography map, anterior curvature map for one of my patients. Look here, the central 3 millimeter is 44.6, 44.9. The difference is 0.3. But here in the 5 millimeter is 39.4 and 43.1. There is a big difference between the superior and the inferior points here in the central 5 millimeter. So the index is higher than the accepted one. So this patient is suspicious. Another one here, it's obviously shown that there is a high steepening in the inferior cornea. So this patient also is highly suspicious. If there is no opacity in this area, or there is no epithelial hyperplasia in the epithelial thickness mapping. This is the warm and the elegant one, and we used to see it in the normal patients. But you may find it vertical or oblique, like in these patients. Both of them are quietly normal, provided that all other maps are okay. So these examples were how to detect the points and how to suspect the anterior curvature map. What about the posterior curvature map? It is not negligible. It's very important to to examine in all patients. Look here, you will find the central 3 and central 5 as well as in the anterior, but the central 3 millimeter is more important than the central 5 millimeters. Here you will find minus 6.6, minus 6.4. This is a good sign. If you find that the superior point is higher than the inferior, still a good sign. And here, this is the numerical value regarding the Q1, Q2 of the back, of the corneal back. Also the quality, the Q value, which is very important. If you find that the Q value is higher in the posterior than the superior, it's a bad sign. Let's go for another example. This is the posterior curvature map for our patient with keratoconus. And actually, this is the 3D map of the same patient. You will find here that there is a great difference between the superior and the inferior points. And here, this is the explanation. And finally, in the MS39, you can see by your naked eye, without numerical values, without maps, the change in the back curvature map. Look here, you will find here, this is the direction, and this is the back surface of the cornea. It's not regular as you see in the normal patients in one line, and regularly like that, the hemispherical section. But here you will find that there is protrusion or the forward movement of this part of the back. Here, this is the high elevation point, and this is the steepening which is happening in the posterior curvature map in this patient. You can see it by the high resolution anterior segment section by the MS39 spectral domain OCT. So put in your consideration to ask for the posterior curvature map even if you have a normal anterior curvature map, because the keratoconus is starting posteriorly and very early changing the back before going to the surface. Look here, this is minus 5.9 and minus 6.7. There is a great difference. Here, the difference shouldn't exceed 0.2 or 0.3 at most. So here, the difference is more than, I think, 1.5 or 2. So this is an early case. Look here, the tangential posterior curvature and the posterior elevation. You will find that there is a correlation between the high points in the elevation map and the high points in the posterior curvature map. So the message, and again, the back curvature map, the back surface and the back elevation by the naked eye. So the message to consider the back, to consider two things. Any difference between the superior and the inferior points in the anterior curvature map, whatever the difference until explained. Also, the posterior curvature map is very sensitive, so the very minute change, especially if it's inferior, you have to suspect to increase your safety profile and to be sure about your patient, and you can go after that comfortably and safely to do any refractive surgery you like. Now I'm going to present the second presentation, okay, about the new tools to complete what I'm talking about, the inferior steepening in the anterior surface of the cornea. In the past, before having the epithelial mapping, any inferior steepening was suspicious, and we may exclude the patient from the inferior steepening test. But nowadays we have a tool which is helping us a lot to know if this patient is actually keratoconic with a pathology, or there is another thing to do, or to make or to cause this steepening, and this patient is still innocent, and I can go for refractive surgery. But I prefer all the time to correlate the epithelial mapping with the other maps. So I have no financial interest regarding the MS39, but I am very fan for this device because I'm using it for more than 2 years with a very reproducible results. Yes? in my opinion, it is still different than having the epithelial mapping from the MS-39 and having the epithelial mapping by the other OCT devices, which is not confined to the anterior segment, because the epithelial mapping with other devices is divided into zones and circles, but the mapping with this device is very, very accurate and very with very narrow points, so it detects the epithelial mapping in every single point on the surface of the cornea. It's a complementary, as I said, with the new tools in the keratoconus diagnosis, artificial intelligence, the corneal biomechanics, and also the epithelial mapping. And let's discuss first, or understand first, the phenomena of the epithelial mapping. You know that the epithelial thickness is around 50 microns on the central part of the cornea. It is thicker in the center than the periphery. It's the reverse of the bachymetry map. So in the normal cornea, you will find that the epithelial thickness map is homogeneous and almost the same all over the central part of the cornea. But the epithelium has a very nice or very helping property, which is that it's continuous and persistent trial to regularize the surface and to keep the anterior surface of the cornea as a regular one to improve the optical quality of the vision. So in response to the protrusion of the cone, the epithelium goes to be thinner to keep this surface regular, so there's a masking effect. So the epithelium has a masking effect in response to the protrusion of the cone apex. So thinning of the cornea, which is a characteristic sign in keratoconus, is formed by the ultimate thinning of the epithelium on the top of the cone apex. In order to keep the better vision and regular surface, as I said. So you will find here the back surface in the keratoconus is going anterior is going forward, while the epithelium goes to be thinner on the apex, not on the other part, but with consecutive thickening around the thin part. So the thinning which is happening on the cone apex is like that of the rodent ulcer, if you remember the pathology. It's with a depth and rounded edge. So it is a thinning, lake of thinning, surrounded by a patch of thickened epithelium. But at the end, you will find that the thicker epithelium on top of the cornea, because of opacity or because of pathology, another pathology like in vernal disease, you will find that there is a thickening of the epithelium, while the corneal thickness is still the same. There is no thinning and there is no cone. So from this phenomena, which is shown by the Dahrenstein in this diagram, you will find that the normal epithelial map is homogeneous all around, as you see, so it's normal patient. But here the alarming sign, the donut sign formation, as I told you about, the characteristic thinning, which is called donut sign formation. Donut sign means thickening, thinning, localized thinning on the apex, surrounded by a border of thickening. So it is one of the sure signs of keratoconus. It's blue in nature, but it's red in blue in color, but red in nature. Actually, the reverse is the red color of the epithelial thickening, which is thick part of the epithelium with a normal stroma. So it's red in color, but very green in nature. It's because of thickening. So this patient with inferior steepening on the corneal topography, it's not keratoconus, but actually because of the epithelial hyperplasia in this part. So this excluded the keratoconus and make you comfortable and assured about your patient, and you can go for the surgery. So please keep in your mind that the epithelial map could change the minds. Look here to this patient as one example. What about this pentacam, in your opinion? You will find that the superior point is 39.9, the inferior point is 41. So there is a difference in the center of 3 millimeter, and 39.8 and 41.1. The difference is less than 1.3. So still, according to the rules, still mild suspicion, no sure sign of keratoconus up till now. Okay, look here, the front elevation, and the back elevation maps within the accepted range of numbers, less than 12 in the anterior and less than 17 and 18 in the posterior elevation maps. And also the bathymetry map is concentric. There is no dome shaped, there is no disfigurement, there is no displacement of the thinnest point, which is that so far. The thinnest point here, as you see, is just minus 0.7. It's more than 0.5, but less than minus 1. So in the mild suspicion zone. One of us may say, I will go for PRK, and other one may say, well, follow this patient up. But up till now, we are not sure about the diagnosis of this patient. Look here at the Palin and Prezio. You will find that the deviation value is 1.6, is less than 2. So we are still in the yellow zone, the mild suspicion. But when I send this patient finally for the epithelial mapping, what I have found, I found here a sure sign of the early detection of keratoconus in this patient, which is the donut sign formation on the cone, on the steep part. Okay, so I could diagnose this patient surely that keratoconus. So I excluded at all the refractive surgery and went to manage the keratoconus. So the roadmap from the epithelial mapping, either to stop, wait, or go. If you have inferior stemming in the topography, you may find one of these epithelial maps. Thinning on top of the steep part, so you have to stop because it's keratoconus. A bit darker green, but still in the equal range, less than 4 micrometer range between the superior and the inferior point. So I'm not sure about, it's not blue, it's not red. So I can wait and follow up for 3 months more and capture this patient again. And finally, if I found it red with thickening, I can go freely. So let's go for some clinical cases. Do you feel safe to do laser vision correction or not in such patient? Look here to this. This is the 6 composite map of the MS39. Here there's a thin cornea, thin bathymetry, but still normal. There is no disfigurement. The tangential anterior curvature map, the difference, there is no difference. There is no significant difference in the numerical values regarding the key reading in the topography maps. Also, the anterior elevation and posterior elevation within normal, there is nothing. Look here at the back curvature map, you will find 6.6, 6.6. But above there is 6.60, down there is 6.68. Very minimal change. It's not significant. But look here at the epithelial thickness mapping. You will find that the part of the central part of the cornea showing a thickening or thinning. You see here, the central part is 54, in the inferior part is 54, in the superior part is 57. So there is no significant difference between the superior and the inferior points in the epithelial map. And also the steep part in the superior cornea here is associated with 59. So 54 down and 59 up, on top of the steep part of the central 3 and 5 millimeters of the cornea. So this is explaining the steepening. So no pathology in such patient, and they can go freely without any worry. It just started with this simple case. Here, look here, there's a significant steepening in the anterior curvature map. How many minutes? 5? Okay. Okay, okay. 54.5 and 45.5 and 47.5. There is a very significant difference between the superior and the inferior points. There's inferior steepening, but what about the back curvature map? The back curvature map 5.4 and down is 7. So there is a bigger difference between the superior and the inferior points. So without going to another maps, I can diagnose this patient, but I will show here the benefit of the epithelial mapping. You will find here there is thinning of characteristic thinning, which is donut sign formation on top of the steep part. So the inferior steepening associated with thinning of the epithelial thickness mapping is a sure sign of keratoconus with no worry. If you don't have the back curvature map, I can diagnose with the epithelial mapping alone, despite the back curvature map is completely within the normal range. Look here at these signs. Another case with the same configuration. Inferior steepening, very minimal steepening, but associated with epithelial thinning. So it is a sign of early keratoconus changes, and I can predict that the patient is going to be more progressive if I did some refractive surgery, even the PRK for such patient. Another one, the same, but here the reverse. Inferior steepening with the back curvature map normal and thickening in the epithelial thickness map. So very significant and very worrying steepening in the inferior part of the anterior curvature map, but there is thickening at the epithelial thickness map at the same point. So the steep because of the thick, and no keratoconus, and I did refractive surgery for this patient with no worry at all. Alhamdulillah, the patient is still okay. I will finish with post-LASIK because the epithelial thickness map is doing a great job in the post-LASIK TIJA, in the post-LASIK patients. Especially we don't rely, as Dr. Omar and Dr. Amr said, that we don't rely on the Benin Ambrosio in the post-LASIK patients, but the epithelial map may give me a very important information about, especially in the regression or the residual errors after LASIK surgery. If I did any epithelial mapping for patients with, especially the myopic patients, surely I will find epithelial thickening in the response of healing after that to compensate for the steepened part, with the flattened part with the ablation. There is some part of compensation of the epithelium, so there is epithelial thickening, which may act as a convex lens on the corneal surface, giving a myopic error. So this is a different calculation regarding the redo. Look here to this patient, very thick epithelium, so no ectasia at all, but there is epithelial thickening and hyperplasia. It's more obvious in the next slide. Look here. Actually, this patient, I did LASIK for her 12 years ago. And she came 3 years ago with this picture, minus 4.5, minus 1.5 cylinder. And when I I examined her with the MS3 line. I found this red elevation in the epithelial thickness map. But the posterior maps, all normal, but there is, because of this obvious and very significant hyperplasia, I think it's around 80 micrometer, the epithelial thickness in the center. Yes, okay. So this patient, just removing the epithelium, just removal of the epithelium will correct a great part of the error. So don't be panic, just ask for the epithelial mapping to be sure that your patient is okay and is normal. And if you suspect any patient with abnormal topography, because consider the epithelial mapping to be sure about your patient, it will detect the very early changes before going to the surface. And thank you so much.